Dr. Grimm is going to present how to build a minimally invasive surgery team.
Okay, many things have already been said, so I skip several of the slides. Excuse me, I have to close it. Just one thing on the fancy mini-invasive instruments. I think they are simple to use and they are extremely helpful in conventional open surgery. Once you can reach it with the conventional open surgery instrument, with these mini-invasives that we often say, give me the mini-invasive needle holder, because even if it's a thoracoabdominal aneurysm and you do a stitch on the backside, you say, I don't have the needle, give me the mini-invasive needle holder, and it works very well. So I think this is something that just we have to learn, and I learned it myself. I'm not porn expert in everything, but I was skeptic from the very beginning, coming from full approach surgery, and then I think we have to stay open for where is the second? Here it is. So we have to stay open, and these instruments are definitely not so bad. Sorry. Okay. I think the main message of this I already said in the last presentation. We only change something if we go away from our personality. I am the head and I am the mega hero and I have some slaves working for me. We won't change cardiac surgery. Maybe we can retire as heroes, but we are actively bringing back our profession. And I think this is, we have to accept. I think mini-invasive, of course it needs experts to introduce this. It needed experts to introduce mitral valve repair via full sternotomy, to implement it, to standardize it. It needs experts for BIMAs, it needs experts for everything to implement it. But this is attractive for the patient, attractive for the surgeon, and it's also an emotional benefit for the surgeon, whatever procedure it is. However, as we discussed, there is still lacking evidence that mini-invasive really changes something. As long as I have the same outcome, so a perfect repair, a perfect aortic valve replacement, which is faster, where the patient recovers fast, I don't need a randomized study. And the cardiologists don't need a randomized study, because when they get the patients back with such an incision, and from another center with such an incision, then they say, okay, send him to this, because the outcome is the identical. So I think, of course, we learn very much from these expert centers, Cleveland Clinic or wherever. They hire a $5 million guy who does nothing else than this. But we are living, at least we are living in another reality. We are living in a university clinic. We have to train young people. We have a working time regulation. We have 40 hours working times a week. And so it's very difficult to implement this into reality. And I think this is a very different approach we have. Our prerequisite, we have 900 open heart cases doing from heart transplant, VADs, aneurysms, thoracoabdominal aneurysms, valve surgery doing 60 to 70% BIMA in all cases. So I think we struggle through the world, and we have some senior surgeons, mean age 56, so they are, some of them are very active, very good, some of them are waiting for the retirements. We have some younger surgeons like Nikos is, so 40 years plus, and we have a lot of trainees. It's now 8 trainees, because we need them for working time regulations. So this is our staff we have, and we have to work with this staff, not meaning that I have a staff of 20 people working for me, because in Austria they would kick me out after a very short period if 20 people would work for me. I have to work for them to provide them a fulfilling life as surgeons. I think this is not just said, but I think this is my primary job there. Introducing, we all know from our introducing, and we knew from changing the people, is the smaller enemy is the ego. So changing a successful habit was always a big issue. They said, I did an aortic valve skin to skin 20 minutes and nothing happened. Those are the surgeons who forget about the high thoracotomy rates, about everything. I think they fear this is a longer procedure is no more valid. We have clear data in our unit that the mean invasive aortic valve is by far faster than the full sternotomy surgery. There's a fear for new complications, new type of complications, bleeding, backache for bleeding, massive bleeding from the vent, from the pulmonary vein, you don't see anything. Then working in the setting of a mean invasive is challenging. I'm fully with you. And of course, we all have the fear of failing. We did it for 20 years. Now we have to change, and I fear failing and maybe losing the importance. So I think the big enemies were, in my view, the other ones. The colleagues, they said, oh, he's on an ego trip. This doesn't bring anything. He complicates simple thing. I am much faster, but to be honest, this is also an arguments of jealousy because he's doing some changes and I'm losing maybe importance. I think this is definitely an issue. Valve surgery is important for our outcome in our portfolio. We are getting patients from all over the country coming to Innsbruck because they have a perfect and durable repair. And they have it via a small incision. But primarily they come for the first perfect and durable repair. No tolerance on paravalvular leaks, no tolerance on residual MR or tricuspid MR. I think this is an issue. And our secondary target is we want the widest as possible, it's not 100%, but the widest as possible use of min-invasive approaches. This means this can only be done by the team. The entire team, and meaning that everybody should be trained in this and should have experience. I already told you about our targets. So we try to implement this in also quite complex, like aortic valve replacement, aortic arch replacement with a Thoraflex. This is a good approach. We skip this. This is just interesting. You see the development. First in blue was the thoracotomy cases, and then in gray is the thoracotomy cases. This is and then there was a change towards the partial upper hemisternotomy. And this is data one of our colleagues published in the Annals of Thoracic Surgery. The full sternotomy, the thoracotomy had longer cross-clamp times, much longer because it's technically not easy, came back by hemisternotomy. And the anterolateral mini-thoracotomy were the simpler patients, were the better patients. The worst patients were always done via were still continued on full sternotomy. So these were selected good patients by selected very good surgeons done. And if we review, there is a lot of bias in there. But median sternotomy, many patients nowadays are in the TAVI program. This is a historical comparison to the anterolateral thoracotomy. There is, of course, a better survival, better 90-day mortality in these patients. But then the sicker patients, again, done by everybody, done in a min-invasive. And this is the benefit of min-invasive therapy. So this is everybody surgeon, sicker patients do have better outcome in terms of 90-day mortality, but also in better outcome in terms of 1-year mortality. And I think a 1-year mortality of an unselected surgical community of 2.02% is a good outcome for these patients, I think. So I think the team was very happy about the switch from thoracotomy to hemisternotomy. They felt a lot of pressure going away. Of course, the proponents of hemisternotomy said, oh, why this is a step back? And they said, no, this is not a step back because you and you and you and me maybe are able to do it, But the vast majority of cases cannot be done by everybody, only by us. The others have no job, because aortic valve replacement is, besides bypass surgery, the standard procedure of our unit. And I think for this, I think it's good because it's less stressful, they feel confident, they feel safe, and I have rather to stop a young surgeon and say, oh, no, do you really think this should be done invasive? And he's in the 4th, 5th years of training, he looks at me, why not? And I said, okay, let's have a look and see how things develop. So I don't have to force them to do it invasive, I have rather now to stop them to do it not invasive. I think it's the surgical technique for teaching our trainees to 30 to 40 invasive aortic valves before they do the first open full sternotomy aortic valve. Cross-clamp times is no different to full sternotomy. I don't know whether sutureless implants do impact on this or not. I don't think so. The topic of pre-op CT scan is already discussed. And the benefit is that Innsbruck has a rather uniform external visibility. So cardiologists from all over Austria say perfect repair in Innsbruck, no tolerance of complications, and such an incision in mitral, it's now peri-alveolar incision. I think the patient should go to Innsbruck. And this is ongoing now for 10-15 years, because Innsbruck 10-15 years had a certain focus on this, and I think this is definitely interesting in sake of our profession. It has a positive outcome on survival, on complication rates, on recovery rates, and if survival is dramatically better in a technique, there is no doubt that also the recovery will be technically better in these patients. And our rehab centers take the patients of invasive surgery plus minus day 7, because they say they can fully mobilize and train the patients after day 7. Full sternotomy, they send home for 2-3 weeks, and then get them in the rehab center, because they say they cannot mobilize the patients or start to train the patients. So I think I stop here, quit the mitral tissue here looking on the watch, so I stop here, but the same is true for the mitrals, I think, and this is an issue that is definitely of big importance for me. Thank you.
Thank you very much for your excellent presentation. Any questions from the audience? Dr. Pasiouras.
Thank you, Professor. The basic concern of the Cardiac Surgical Society should be whether these techniques are able to fight back these developments by the cardiologists. So what do you think would be the future of cardiac surgery in general? Because now recently I see developments like they developed even the transcatheter mitral. So if you compare this very attractive to younger surgeons, minimally invasive techniques.
We had with Professor Calfiore, we had a discussion yesterday night on this. If my young surgeons ask me about the future, I say, in the future we will need only the very good heart surgeons will be needed. The average and the lousy surgeons, which we have now still in our staffs, we won't need them anymore, and the society won't need them anymore. Society will ever have need of surgeon who is able to do a perfect redo surgery, a triple valve surgery, safe and fast. So I think I am not a big fan of the interventional heart surgeon, because you cannot do on a high level surgical techniques, conventional, invasive, whatever, and transcatheter, because the day has 24 hours and working time is 6 hours a day if you calculate it down, and you cannot become a perfect specialist on transcatheter and surgical techniques. This is, at least in my understanding, maybe I am wrong, so I think a surgeon now is now in a crossroad. Either I become a very good, and I think if a good surgeon becomes a transcatheter surgeon, he's better than a cardiologist because he's more understanding. Either I become a transcatheter surgeon, or I focus on surgery. That means that I can do a redo without need of an ECMO, without need of whatever, because we were trained in redos, in coronary redos, we were trained in complex surgeries, and I think this is very a losing experience now, because we all say always, oh, he has some calcium in the ascending aorta, he needs a transcatheter valve. No, he doesn't need a transcatheter valve. He needs a good surgeon, I think. And this is, I'm very emotional in this topic, because I think it's always the transcatheter answer to a difficult situation. No, it's a better surgeon on a difficult situation answer, for me. This is my personal opinion. And you see, I'm very emotional in this topic.
I totally agree with you, but how do you fight the cardiologist?
I don't fight the cardiologist. I convince the cardiologist. This is not a question of fighting the cardiologist. I think I have to convince them. We saw it in the before Syntax came out. We saw it that they tried to stent everything, but now the cardiologists realized that they cannot do everything, and even 20 stents cannot solve the problem. And I think the cardiologists are not, as we often say here, they are stupid assholes. No, they are doctors as we are, and they realize that a complex multiple type C lesion is not a target for a cardiologist. And they realize that, and they also realize if they see day by day that we operate standard, the entire program of Innsbruck is now 1% mortality for entire aortic valve replacement, which is by far much better than the TAVI program, which also is done in heart surgery together with the cardiologist, but it's a heart surgery program in Innsbruck, together with the cardiologist, perfectly guided by Nikos. Yeah? But so I think if we have in a broad mass, not they send patients to me or to him because he does good surgery and things, but we can say to the community of heart surgeons, meaning that we have to train and to broaden this experience and the outcome. It's the same with the BIMAs. Yeah? Still BIMA is dramatically underused. This shouldn't be. The surgeons for 20 years they say, but now we come with the BIMAs. Yeah? But I don't see the BIMAs in the statistics. They are not here. So I think we have to get out of the comfort zone, and we have to get away from the ego trips that I can do it, and if I can do it, I leave all others behind me. I think we have the responsibility to train our young surgeons adequately. I was not trained. I did it myself. But I was working in my time 120 hours, and I'm still working 120 hours. So the gap between the young ones and my generation is increasing now, and it's progressively increasing. And I think that's the issue. We have to change our habit in training of the young ones. Convince the cardiologist as a society, I think, with good general outcome. And not accepting that elective bypass surgery dying, and this may not happen. This is a catastrophe. An elective aortic valve dying is a catastrophe. Nobody blames you if he comes in under massage or whatever. But if the patient walks in and says, hello, I'm patient X, I need bypass surgery tomorrow, and he is dead or has severe stroke or severe infarction, this is a catastrophe, and we have to avoid this by training the young ones. Say, okay, look at this, how you stitch this cannot happen. So I think we have to improve. She just did and said the cardiologists they are our enemies. No, they work maybe better.
Thank you, Dr. Grimm, for your passionate presentations. Thank you so much.